Hello, and welcome to Medical Center Hour, the University of Virginia's weekly public forum on medicine, healthcare, and society. I'm Marcia Day Childress from the Center for Health Humanities and Ethics in the School of Medicine. Thank you for joining us today. Indeed, please come every Wednesday. The slides before and after this program provide resources for further study, bookstore links, and information about continuing education credit for healthcare professionals. There's a link to our center's website for information about today's presenters and a link to Medical Center Hour's YouTube channel with program recordings. This program's recording will be posted to YouTube. On Zoom, we handle audience contributions using the Q&A function. Write your questions and comments there. We'll monitor your questions as they come in. They'll be the stuff of my conversation with our presenters at the end of the hour. Our program today is Elderhood, Redefining Aging, Transforming Medicine, Reimagining Life. Even if this pandemic has made us more aware than ever of the hazards of being old, with older persons accounting for the majority of COVID deaths, only a fraction of the risk of old age is actually biological. At an historical moment when most of us will live well into our 80s, 90s, or beyond, we've actually created for ourselves a world that's almost exclusively focused on youth. It's time now to define, design, and empower this new, nearly universal elderhood. Geriatrician and writer Louise Aronson calls us to do just this in her 2019 book, Elderhood, for which she drew on both her clinical experience and her creative abilities. This was a remarkable volume. It actually just went into paperback yesterday. This book is part memoir, part medical challenge, part model for change. And in it, she reimagines and advocates for old age not as a disease state, but as a vital phase of being human. Louise Aronson is professor of medicine and geriatrics at the University of California, San Francisco, where she also directs the medical school's medical humanities program. Responding briefly to Dr. Aronson today will be UVA geriatrician and health humanities faculty member, Justin Mutter. Both presenters appreciate that redefining aging requires corresponding transformations in and of medicine and healthcare, but it also entails reimagining life, a daunting prospect, but what better time to start that than now on the horizon of a post-COVID world. Elderhood is our Kopacka Family Foundation lecture in the health humanities. A gifted writer, Louise Aronson uses stories in her book, Elderhood. She has a way with stories, her own stories, stories of elders she's cared for, stories that herald new views of aging. This lectureship has a story too, itself grounded in a life story. Established in memory of Dr. Kopacka Rao by his wife and children, two of whom are physicians, the Kopacka Family Foundation seeks to improve care of patients, especially clinicians' communication with older persons and their families. A medicinal chemist from an impoverished village in India who earned advanced degrees in science, Dr. Kopacka Rao had a successful career in the United States as a pharmaceutical researcher and professor of pharmacy. He cared deeply about scientific discovery, teaching, and just being a good person. But his last illness and hospitalization were complicated by poor communication, the healthcare team failing to attend to him as a person. Our Kopacka lectures and lecturers speak to how those of us involved in healthcare might better relate to our fellow human beings, how we might better honor one another's stories, express care and connectedness toward one another. Today's Kopacka lecture is a centerpiece of UVA's Excellence in Education Week, which celebrates innovation and quality in health professional teaching and learning. In this spirit, we welcome Louise Aronson for her reimagining of elderhood and what she might teach us, including new generations of healthcare practitioners and healthcare educators. And now please welcome Louise Aronson and Justin Mutter.
Thank you so much for that introduction. It's a pleasure to be here, although I actually wish I were there, which was the original intent with all of you. But I'm really looking forward to this and to the conversation with Justin. So I'm going to jump in now with my slides. And I want to start by challenging anyone who's listening to think about, what age do we become old? And you'll see I have quite a range up here, and that's because there was a headline in the New York Times a few years ago that talked about a relaxation retreat for stressed older workers in Silicon Valley. And in order to attend that retreat, you had to be a particular age. You had to be an older worker. In other words, you had to be 30 or older. So, old age is a lot in the eyes of the beholder. I also gave a talk at a huge retirement community out here in California. And I would say the average age in the room was in the late 80s. And as I moved through these numbers, some people raised their hands, but there were a lot of hands that still weren't raised as I got to 85, 90, 95, and 100. Although as I moved through those numbers, there was also a great deal of giggling. So what age is old? Well, it turns out it depends a little bit on our perspective. The Pew Research Center did a study a few years ago, and when people are young, when they're under 30, they believe the age of becoming old is 60. When they're older, particularly 65 plus, they place it at about 74. And this is actually pretty interesting because across cultures and across time, most people have placed old age as beginning somewhere between 60 and 70. And also because when we become old in the way we often define it biologically, sometimes appears to have to do with our life experiences. So people who have had grave illness or huge amounts of stresses have a phenomenon called accelerated aging. And people who are more fortunate may age more slowly, even biologically. But the fact that there are cultural overlays is shown by this second part of the Pew study, where men and women were both asked at what age men become old, and they agreed that it was age 70. But when asked at what age a woman becomes old, men said it was 68, and women said it was 75. So old age, sort of like youth, kind of depends on where we're sitting. Now, some of you may have noticed the photograph in the upper right corner here, and I often use this with medical students, and I ask them what they see, and they tell me about the medications on the bedstead and the books. So they think, oh, well, he's got some diseases, but, I guess he can still see well enough to read, and he's eaten pretty well, and they assume this is his digital device. But this was actually the Nobel Literature Laureate Isaac Bashevis Singer. About 15 years before his death, and in those years, he published 12 books, won the Nobel Prize, published fiction, nonfiction, children's books. And he was in bed because that was where he liked to start his day and do his writing, not because he was sick. So, what you're seeing and what you're told can vary. Just because someone's old doesn't mean they fulfill our usual stereotypes. Now, old age itself is kind of interesting. We all know this is the age with the most older people, and old age up until the last couple of years was getting older. And this was partly proven by a guy at Stanford who's actually an economist called John Chauvin. And what he looked across time, and this graph shows the last century, and sort of defined middle age by having a 1% annual risk of death, old age with a 2%, and elderly with a 4%. And what he showed was there was a many decade shift in when these life stages happened from 100 years ago to the present. So what's going on in our environment can also determine age, although notice that the incipient sort of old age window is still in that 60 to 70 range these days. Of course, then came COVID, and this graph is from last spring and basically shows that the people at highest risk are over 85, then comes the people in their late 70s, early 80s, then the people in their 60s and 70s, and so on down the line. So does age matter? It does. That's not the whole story, though. So I'm going to start by discussing how we might redefine aging. And this is a really important slide because it shows you all the words that old people like to have used to describe themselves. You can see the list is really extensive. So in contrast to, for example, if we were talking about someone's child and we called them an infant or a toddler or a child or a tween or a teen, or even if we spoke about ourselves as a young adult, an adult, or a middle-aged adult, would anybody have a problem with that? Probably not. And yet when we do studies of older people, nobody likes any of the terms. They don't like senior or old or elder or elderly or geriatric. Even though if you actually look up the definitions of these words, all they mean is a human being who has been alive longer than others. Actually, in the medical literature, we are required to use the term older adult, which I would argue is actually ageist because older is a relative term. So I am an older adult than my medical students, but we're both adults. An adult actually panders to ageism because what it suggests is that you're only an okay or a valuable person if you're an adult. And actually, our society kind of plays that out because the greatest times of poverty are in childhood and old age, and the resources are usually inadequate for those life stages. But it is a problem if you don't even have a language. And if you don't have a language for the substages of a major life stage, because how then do you have policies, healthcare, etc.? Of course, we do talk about old age. We tell certain stories, and I'm going to mention 4 of them now. One of the popular ones these days is that if you do everything right, some kale, some blueberries, maybe some Botox, you as a good American do not have to age. I am sorry to inform you that human mortality is holding steady at 100%, and you can die young or you can age. And what I want to convince you in the next little bit here is that the aging is really by far the best option. We're also given these exceptional senior stories, the person who is exceptional. So the problem with exceptional people is that they are exceptional, which makes the rest of us feel like failures. So that's actually not a good way of motivating people. And I will just speak to the woman on the right here that if I were to have done that at age 8 or 18, I would have required orthopedic surgery, and I most certainly would not attempt it now. So she's exceptional. And then there's this wonderful thing called the silver tsunami. So think for a moment about the upsides of a tsunami. Right, so there aren't any. So this suggestion is that the aging of the population is an exclusively bad thing, this from a society that doesn't want to die, and also that there's kind of like a them versus us, as if most of us wouldn't become older people. And then there's sort of this notion that aging is really bad. So here you have this like gorgeous young woman, and she is the poster person for anti-aging. Now, I suppose I would love to look like that at any age, but I think she'll still be beautiful because she is beautiful. There's also a huge academy of anti-aging medicine. So imagine like anti-youth medicine, anti-woman medicine, anti-brown people medicine. You just wouldn't have it. So this is like, and if you think about aging as a synonym for living, because that's essentially what it is biologically, we have a problem. But there's also this lie that age is just a number. Age absolutely matters. I'm going to do one last point on this ways of seeing, and this is from a book and later a television series by sort of the philosopher or the thought leader, John Berger, who was at UC. One of this one on the right, where you see, the brush strokes that are famous for Impressionism and the different use of color, and it's a pathway. And, for those of us who've been locked up in small rooms for the better part of a year, it's kind of attractive going out into nature. But you look at this very differently if I tell you that it was Van Gogh's last painting before he committed suicide. Then you see the birds circling. You see the pathway into eternity. You see the lines as something different than what you might have seen them as a few moments ago. And I would argue, as Berger did, that what you know about something and the context of it really determines what you see, kind of like that photograph earlier of Isaac Bashevis Singer. I'll give you another example here. Here's an old woman on the street. She's hunched over, the doctor in me is thinking, osteoporosis, dowager's hump. She's got glasses. She's bundled from the cold and seems to have an extra jacket. So we know the skin thins, people feel the cold. She's by herself. Most women of this age have been widowed or otherwise unpartnered. It looks kind of sad, but here is this same person once she got to work, which is where she was going, and the people on either side of her whom I cut out of the picture, who you cut out of the picture also matters, were her Secret Service detail. So what we're told determines what we see. Here's some things we're not told about aging. This is called the U-shaped curve of happiness. And what it shows is, and apologies to those in middle age currently, is that the really tough time of age is, sort of 40s and 50s. Justin is smiling. And actually that happiness, and this is from data from, countries across the globe, not the poorest of the poor, but most of the others. And there are a variety of correlates of this. Not only does happiness go up, anxiety goes down. You can see how those would be related, and you can also see how they would result in higher life satisfaction. This is one of the true stories of aging that we do not hear. This shows up in a variety of ways. So this is from a health reporter called Judy Graham, who writes mostly in Kaiser Health News, but also for New York Times, Washington Post, et cetera, and covers aging really well. I suggest you follow her if you don't already. So she wrote this article a couple years ago about why so many older Americans rate their health as good or even excellent. And she then posted on Twitter that the first comments that she got were all denial, denial, denial. People literally could not believe that older Americans would rate their health as good or even excellent. And what this was a compilation of many, many studies of all sorts of different people. Now, was an 80-year-old saying that her health was the same as it was at 30 or 50 or even 60? Of course not. What they were saying was that their health was good or even excellent, such that they could spend their days as they wanted to and do the things that mattered most to them. Meanwhile, my own organization, the American Geriatric Society, reinforces this notion that words like the aged, elder, elderly, and senior should not be used because they connotate discrimination. And I really want to emphasize that we have to push back against this. The words are not the problem. The problem is the prejudice with which they are associated. And let me show you how this plays out in public areas. So this is from Boston's anti-aging campaign, which they called Age Strong, in reference to the murders at the marathon a few years back in Boston Strong. So this is this stunning 86-year-old, and she says, I'm a lot of things, but over the hill isn't one of them. Well, if you're more of a humanities person, you might be thinking about the arc of a story. And if you're more of a science person, you might think of a bell curve. But no matter which way you look at this, an 86-year-old is over the hill. So the problem is not being over the hill. The problem is associating being over the hill with being a human being of lesser status. All the more so since if the average life expectancy in this country is in the 70s, that means most of us are over the hill by 35 or 40. That flies in the face of everything we see and experience every day with our colleagues in our society, on the news, on social media. People over those ages are part of society, soup to nuts, basically. A second image from this, which speaks to the other part of aging. So this is an 83-year-old who says, he's a longtime boxer and he's many things, but not frail. But you look at him and you know that unless he dies fairly suddenly, he will become frail, and he will probably become frail in the next few years. And by standing up in this way, he has essentially contributed to a society that says that his value exists only insofar as he remains not frail. And that when he becomes frail, it's fine to ignore him or write him off, that his value is in his not frail status. I would argue that his value is in his status as a human being. So this from the writer Ursula K. Le Guin, who wrote one book at least that touched on aging in her later years, and obviously many, many other great books. So two of my favorite quotes. To tell me my old age doesn't exist is to tell me I don't exist. I love that. At all ages, that is true. Part of who we are is defined by what age we are at a given moment. And then this little bit of humor. If I'm 90 and believe I'm 45, I'm headed for a very bad time trying to get out of the bathtub. So I love that. Age is not just a number. Part 2, transforming medicine. So this is where I went to medical school. And when I went to medical school, and still today, if my medical center is to be taken as an example, although we do better, we basically learned that human beings come in two categories. There are children and there are adults. They are mostly male. We know this because when they're female, they're usually pregnant or requiring a mammogram. And they're mostly white because if they're not, then they'll have sickle cell disease. And they're mostly straight because if they're not, they'll have AIDS or something like that. So we really have a pretty narrow sense of what counts as normal in medicine. And the specialties that we focus on are pretty much the same specialties. In fact, exactly the same specialties that I had in the 90s, that my father had in the 50s, and that basically were brought in with medical education changes at the turn of 2 centuries ago. Very little change. You'll see that there's obstetrics is required, although fewer than 3% of doctors ever deal with pregnancy or babies after their training. And family medicine has to do with young families with children. There is no picture of the highest per age group, highest population users of healthcare, the older people. So basically, this is an antiquated approach. Similarly, for research, we learned in the middle of the last century that when you said you weren't going to include people in studies because they were different and then applied the results to them, sometimes things didn't go well. So we still, for example, talk about the way women often present with heart disease. There are more women with heart disease than men these days, but we still talk about their presentations often as atypical. They're actually typical if you're a woman, but that was because the initial studies were done only on men. So in the 80s, the NIH issued a policy for the inclusion of women and minorities in all research when the results would apply to them. And in the 90s, they mandated the inclusion of children. When did they mandate the inclusion of older adults, for whom so many of these procedures and drugs are developed? In 2019, just 2 years ago. This despite years of data, so I'm relying on some older data, showing that risks go up. So this is from adverse drug reactions. So basically what happened was older people weren't included in the drug trials, and then they were more likely to have adverse drug reactions, and then old age was blamed rather than flawed science. And indeed, we often have had this lumped category of 65 plus, when indeed the difference between a 60-year-old and an 80-year-old in terms of risk is significant. But sometimes things don't change. So this is the CDC vaccine schedule, which just came out. This is the 2021 schedule. Vaccine schedules are set based on a few things: biology, immunology, likely social behaviors. So for children, there are 17 subcategories up to age 18. For adults, we have 4 categories, one of which is called age 65 and up. This, from an organization that you will see in a moment, shows huge differences in age response to COVID, one of the things where we're really focusing vaccines these days. And yet we have 3 categories for adults, 17 for children, and 1 for people age 65 plus. Now, my oldest patient was 111. So are we saying in that half century there was no biological, immunological, or behavioral changes? That's ridiculous. Flu tells us a lot about this. So this is from a couple years ago, but this is from our Stat News, which is a great source of health news. So they said hospitalization due to flu are also on the rise, with highest rates among kids under age 4 and older adults. Then they talk about how last week the CDC reported that 4 more children have died from flu, bringing the number of pediatric deaths to 11. So of course, a child dying is horrible. But there were 22,000 adult deaths, the vast majority of which were in older people at the same time. And yet numbers were not provided. 22,000 versus 11, not even worthy of mention. Part of the reason was this from the San Francisco Chronicle. People age 65 and older are the most vulnerable to flu. Reporting their deaths is problematic for two reasons. One is it would require too much time and money, right? So COVID has required a lot of time and money. I'm not sure why we're spending so much time and money on this crisis, because it's very expensive. That this is just like crazy logic. And their cases are often complicated by multiple health problems that make pinning a death on the flu challenging. Well, let's say you're a 79-year-old and you've got some heart disease and some arthritis and your thyroid is low and you have high blood pressure, and you've even had a bout of heart failure, but you've gotten over it, and you're living your life and you're doing fine. You take a bunch of medicines, but you're living your life. You feel fine, and then you get the flu, and then you get pneumonia, and then you go to the hospital, and then you die. Now, maybe part of your death was also getting heart failure, but the fact is you got the flu and then you ended up dead. So we actually could be counting these numbers. So this from the CDC also right now, if you go to their COVID page, you will see all the things that a person who wants to know about COVID needs to know. There are all these categories: symptoms, testing, vaccines for getting sick. Oh, and then look, there's a whole subcategory for children and teens. And that leads to a pull-down menu with 9 different elements. Now, I'll just say that children and teens, if you take people in their 20s as their standard, children or teens are 9 to 16 times less likely to die. Older people are 200 to 630 times more likely to die. Is there a category here for older people? There isn't on the surface. If you dig down, you will find them under people at increased risk. Now, this might not be an issue if we hadn't already called out one age-based population, but we have. So this then becomes ageism. Older adults are at increased risk, and they are divided into people with certain conditions, people with extra precautions, but there's not really any specific information that is analogous to that which is given for adults, or that which is given for children. And let me say, there is an abundant literature on different presentations of COVID in older adults, on different temperatures, and I will show you a tiny bit of this, but it's not really a COVID talk. I just want to make clear that this is not for lack of information. This is structural ageism, which may explain some of the reasons why people die. Yes, the immune system changes. Yes, people have comorbidities. Yes, biological risk increases. But the social, the structural, the medical decisions that we have made and not made have really influenced these numbers tremendously. Look at the differences in risk as you move through age groups. And also look at this sort of liminal zone of adulthood. There are distinct categories. This increases from double digits to sort of triple digits in middle age, and then we go into 4 digits. There are reasons why we would benefit from really acknowledging the different parts of the human lifespan more explicitly. So this is the graph I was referring to about temperature. It's a little busy, but basically what it shows is something that we in geriatrics have always known, and something that Italian doctors dealing with older patients published in February, so informed my response to the pandemic from the beginning, which is that the CDC and my medical center's guidelines for when a fever counts for COVID are actually adult-centric. That if you want to capture most older adults with COVID, because they're less able to maintain body temperature, because their normal temperature tends to run lower, you need to set a different set point for screening. There is a lot of data on this. This was just an article from 2 huge data sets from October, but it's not part of any public health guidance. This is systematic and structural ageism in medicine and healthcare. But society plays its part too. So just when people were dying in nursing homes, we couldn't actually get testing in nursing homes. or PPE, even though my city was saying that the PPE by May or June when these were published was 100% in healthcare settings. So they target nursing homes with responsibilities of healthcare settings, but then they don't count them or provide them with the testing and PPE other people had. This despite the fact that if you were a Hollywood actor or say a politician, participating in super spreader events, you could get tested daily. But the people who were dying could not get tests. Meanwhile, governors, including my own, this is from California, were cutting services to people at home, sending them into nursing homes where they were likely to die. We actually pushed back against this and the cuts were not made. Then you had people like this woman who said, call me a grandma killer. I'm not sacrificing my home food on the table. So basically she wasn't going to do social distancing or masking as of May 6th, which is especially ironic and speaks to one of the particular challenges of aging, because here is a picture of this woman with her child. She is what our geriatrics colleague Joanne Lynn would call a grandmother in training. Right? And I hope she lives to be a grandmother, but she literally can't imagine herself forward or see the value of perhaps her own mother or other people's mothers or grandmothers. Time magazine had this article, Road to Recovery, How Targeted Lockdowns for Seniors Can Help the US Reopen. And I feel like the US there is a little ironic. It's like there's us and then there's the seniors, as if the seniors aren't part of us. And this in an international journal from an ethicist, is age discrimination acceptable? The timing here was ironic because it was the movement for racial justice. If you had said racial discrimination acceptable in pandemic, there would have been an uproar, but this was a legitimate conversation. Now, I'm not meaning to equate those. They have some overlap and tremendous differences, but I think once we allow the toehold or the foothold or the leg in the door of discrimination of one kind, we make it much easier to discriminate against people of other types. This was from New York Magazine saying, looking historically at America's treatment of elders. And this reporter came to the conclusion that the horrific totals from nursing homes were not inevitable. The virus is an efficient killer, but it has its accomplices. And this really speaks to the ways for COVID in particular, but for aging in general, that yes, there are real biological factors, but a lot of what we blame on biology is due to policies and culture. So she talks about how governors calculated the risks in front of them, and as hospital beds ran low, shifted the burden to those least able to shoulder it, forcing the sick into nursing homes, which relieved local hospitals, but sacrificed the elderly. So they got lower standards of care and they brought their COVID with them into these congregate facilities of the most vulnerable Americans who then died. But it wasn't necessarily all Americans equally. So this looks at non-Hispanic Blacks, Latinos, Latinx, Native Americans, and Asians, and shows that COVID mortality is higher in each of these groups, most especially for Blacks and Latinos, than it is for whites. Indeed, look at these numbers. If you are between the ages of 75 and 84 and you are Black, your relative risk is 889. Right? Latinx, 535. So prejudices can be synergistic in the most nefarious of ways. This was a research letter in JAMA Internal Medicine about the exclusion of older people from vaccine and treatment trials. I want to add a caveat here because of the NIH requirement of 2 years ago, they actually did include some older people. This is much better than it would have been had this pandemic struck 3 years ago. So we are making progress, and the numbers were not proportional, and they often ended at age 80 or 85, which is not actually where the human lifespan ends. And then JAMA, speaking of structural ageism, published 11 viewpoints in September about the pandemic, including one from pediatrics, but there was nothing about aging included. These were supposed to be the specialties that were mostly affected by the pandemic. So Bob Butler was a psychiatrist. He was the founder of the National Institutes on Aging and the first department of geriatrics in the United States at Mount Sinai. He wrote a book called Why Survive, which won the 1975 Pulitzer Prize in nonfiction. And what he wrote is the tragedy of old age is not the fact that each of us must grow old and die, but that the process of doing so has been made unnecessarily and at times excruciatingly painful, humiliating, debilitating, and isolating. I actually feel like we're making some progress. There are more older people, they're speaking up. There is actually another cultural generational difference happening that is really pertinent, which is that the two most recent generations of older people have been the silent and great generations. So people who basically were stoic, carried on, took discrimination and just, put their chins up and kept going, didn't speak up. Right now, the rapidly aging population is baby boomers. And I did a program with Richard Eisenberg, who publishes Next Avenue, an online publication that covers aging really nicely. And he said, he's a boomer. So he said, well, when we were young, we used to think, boomers were all about youth, but it turns out we're all about ourselves. And now we're old, so look out. So there are generational differences in what people bring up. So how do we reimagine life? This is the classic portrait of old age. You go into this hideous medical setting and eventually you move forward through the tunnel into the ultimate light. Not a good moment. This I'm stealing from The Pandemic because it was from a February JAMA article. And these authors said, history suggests that major crises such as wars, natural disasters, and pandemics can serve as a tipping point for proactive collective action. For example, reflection and lessons from the aftermath of World War II led to the creation of progressive institutions for that time, such as the UN, the WHO, the National Health Services in the UK. The current moment presents an opportunity to think boldly and to imagine a better world beyond the tragedy of COVID-19. And I certainly think part of that is a world in which we can all look forward to safely and with respect, dignity, and opportunities grow old. So as you've already heard, my bias is that there are three acts in that great Aristotelian way of Act 1, 2, and 3 to life. A beginning, a middle, and an end. The beginning is childhood, the middle is adulthood, and the final stage is elderhood. And if we would do for elderhood what we have already done for childhood and adulthood in terms of services, medicine, and everything else, I think we would have a much better world. So I'm going to show you some ways I think we can make that happen. Part of this is creating communities for all people. So you can look this up. It's called Age-Friendly Communities. World Health Organization and many others have adopted this. It just shows how it's through all parts of life. I do think they have conflated some things like community support and health services. I would split those. Civic participation and employment, those are two different things also. So I actually think there are more than 8 categories here. To my count, there's 11, but you can really see how in every part of life this is relevant. Let me show you how this works. So these are pictured a movie theater, a door handle, and a bathroom with the shower in a tub that's, I don't know, 3 feet high. So that's a movie theater that people can enjoy also, no steps required. This is a door handle, which is actually great for COVID, right? We could use our elbows, not our hands, keep our hands clean, much better for arthritic hands. And here's another stylish bathroom. Obviously, this is not one that many people can afford, but the point is that old doesn't have to be ugly, and we can have things be functional for people of all ages. Many of the changes we would make would help all of us. Which is not true the other way around. So I like to have people guess at what these are. They're actually hearing aids that look like cufflinks. There are also things that go in your teeth now. And I will just say, as the daughter of someone in her late 80s, it's pretty hard to find clothes. My mother would never dress like this. But you get shorter, which means your ribs are closer to your hips. There are marketing opportunities out there to help people look good and feel good as they age. The better you look, the better you feel, the more likely you are to attend to health behaviors. The lower the costs on society, the happier the human beings and families. We need to foster an anti-ageist healthcare system and have equity across the lifespan. You know, we talk about kids and adults in all sorts of parts of healthcare. Whenever we do that, we need to add elders. Pediatric medicine, adult medicine, geriatric medicine. Now, I will give a caveat here that I think many of my colleagues, while whining that geriatrics is small, have actually made it small. They use a logic that nobody in marketing would ever use, which is there are so few of us, let's focus on the oldest and frailest. Biology and society both show us that old age lasts for decades. And what we need is people with the skills and knowledge to take care of people from their 60s or 70s onward through the substages of old age. So I am pushing my group to do this and hope all of you will push the health system generally to include old people in everything it does and thinks about. I like to use this example for how we open that up. This is what computers initially looked like, and they were of use to not too many people, few nerdy guys. Then it got this way, still not so useful. Then this guy came along and said, hey, if these things are so powerful, couldn't we make them useful to everyone? And also, do they need to be so ugly? I think this kind of sums up so much of what we do and don't do for older people. What we do is limited and ugly. What we could do is expansive and could be beautiful, fun, creative, stylish. We need to demand intersectional data. We have begun to see that with COVID, and yet the vaccine schedules remain the vaccine schedules. But we often hear headlines like this, like people over age 65 and members of minority, racial, and ethnic groups are disproportionately represented. You can actually be both those things simultaneously, and then things are really bad for you. So we need a system that can acknowledge those nefarious synergies, as I mentioned earlier, and give us these categories, but also show how they play together and what we can and should and must do about that. You can see here in California, different rates of COVID in older people really vary, so that people who are Latinx are disproportionately affected. You can see nationwide that Black people are 9% of the population and 37% of COVID disease. We need the right numbers to be able to make the right policies and decisions. I think we need to acknowledge at this point that healthcare, medical research, and medical education are racist, sexist, and ageist. And I don't like to throw out those terms, but there is abundant data. It does harm. It costs money. It is antithetical to what the healthcare system is supposed to be. I still laugh at women's health because women's health, is a great thing, and we have a center for it. And then there's all the rest of health. So is the rest of health for men? It's kind of like, white health and brown and Black health, adult health, older health. We need to figure out how to deal with our human complexity and make the system reflect us in all our diversity. So that includes how we think about age. So this is a typical lifespan chart. You can Google any number of them. It shows 4 categories of childhood from infant to teen. 4 categories of adulthood. I'm probably in this last one now, especially with my little COVID weight here and my glasses down here. And then 1 category for old age, which really flies in the face of what is true. So let's show the whole picture of aging. There are many more years of old age. And when we're speaking about the lifespan, we need to speak about the whole lifespan, because if people think they'll go from 60 one day to a wheelchair the next, that's worrisome. It's also inaccurate, and it creates a world in which the people in the wheelchairs are all the more devalued. We need to call out ageism. So this is the Diversity Matters banner and poster for UCSF. It talks about race, religion, country of origin, sexual orientation, gender, ethnicity, and ability. It does not talk about age. And I guess one could argue that that's honest, because we have a very ageist medical center. So maybe they're being honest, but I actually think we are all so ageist that it just doesn't enter into people's mindset. And this matters for all of us, because actually there is a huge data that shows that people with more positive attitudes toward aging lead longer, healthier lives. So negative stereotypes means you will have a cardiovascular event 7.5 years earlier than people with positive perceptions. This manifests in a couple of ways. One is you're more likely to do behaviors to keep you healthy if you think your life has value as you grow old. The other is negative age stereotypes lead to high cortisol levels, which increase stress, which leads to accelerated aging. This affects our brains and our cognitive function, our recovery from disability. It's pretty much ubiquitous. So I want to close up by just saying, beware the single story. This is one of my favorite TED Talks of all time by the incredible Nigerian-American writer Chimamanda Adichie. And she talks about people, her roommate actually in college, seeing her as a person from Africa who must have grown up with flies in her eyes when in fact she was quite privileged. I think when we tell a single story of old age or of any category of human being, we do everyone grievous harm. So I just want to leave you with the thought that what if the greatest limitations of aging come from our imaginations and policies, not our physiology? And thank you for your attention.
Well, thank you so much, Dr. Aronson, for that wonderful talk, and thank you for your larger book. I know there's so much that could be said on this, and so much amazing discussions we could have in a short period of time. And there's a lot that I could say. There's a lot packed in here, and I want to just sort of pull out one theme and focus on that briefly, and make sure we have plenty of time for what I assume are many questions from our participants today. But I want to focus on the structural aspects of the ageism, because I think that it's something that is incredibly overlooked. We tend to think about the political economy of bias as being attitudes, which are certainly there, as you have said, but also, as you have also said, that these attitudes are ingrained in structures that are very strong and very powerful and very present in our lives. And so, as is often the case, I'm going to start with just a really brief poem, because that often helps us imagine our new language. And this is from the poet Jane Kenyon, and many of you may be familiar with this poem. She wrote it as she was with her husband, the poet Donald Hall, with his mother, who was terminally ill at that time. It's called "In the Nursing Home," and I'm not going to read the whole thing, but she talks about picturing her mother-in-law as a horse grazing a hill pasture that someone makes smaller by coming every night to pull the fences in and in. And the poet keeps going and says, she has stopped running wide loops, stopped even the tight circles. She drops her head to feed, grass is dust, and the creek bed is dry. And I think a lot of times when this poem is taught, everybody focuses on the metaphors of the dry creek bed, but they miss that key point. Someone is pulling in the fences. And that is where the circles of our collective elderhood are not just being tightened by natural law, but by many other agents, by many structures, be they social, political, economic, that our loops are getting narrowed, not just that they are being narrowed naturally over time. And of course, this is no news to any older person or any caregiver who has tried to navigate our very labyrinthine and complex medical or social care system. And it's no news to any healthcare professionals that focus their career on geriatric person-centered care. And I think this is what makes Dr. Aronson's contribution so powerful. She calls to our attention that there are two different but very interrelated political economies at work here that we have to push back against. There's the first that I mentioned, that it's the political economy of bias. And that bias is ingrained in these institutions that would pull our fences in when it comes to reimagining our elderhood in positive ways. But there's also something else that you talk about in your book, Dr. Aronson, the political economy of burnout. And I think that is very closely connected with this political economy of bias. And that's the many caregivers, the many healthcare professionals, loved ones, older people who are working day and night to push back on those fences that would be pushed in against us. And I think that is an incredibly strong group, and that is an incredibly strong group that is reimagining, as you have pointed out at the end of your talk, what elderhood could look like. And so I just want to leave us with again a word that you use in your book, that there are new paradigms for aging that are vying against the old, and we are all agents in this political economy. And what that elderhood looks like, as you say at the very end, that's up to us. There's the elderhood of now, and there is the elderhood of what can and what should be, and we look forward to that. So thank you.
Thank you both, Louise and Justin, for your comments. We have some questions, but also just jumping off one of Justin's points. You said we are all agents, and I realized we are all agents and we are all aging. And so we all have a stake in this. And now indeed is a good time to start reimagining. So our first question actually is consistent also with our Excellence in Education Week. So how might we change medical education? I would also add nursing education, other health professional education to reflect a more holistic understanding of elderhood, such has been presented today and in your book, and how also to decrease the ageism that seems to be quite built into a lot of medical training.
Yeah, huge question. I think the ageism is built into society, and medicine is made up of people who are well acculturated. So we're all well acculturated to ageism. We can all be part of the solution by just raising it. I mean, it's really interesting since, as readers of the book will know, I had been dyeing my hair brown since my 30s when it began to go gray as a result of medical training. I'm convinced, since no one else in my family had that happen to them. Anyway, so I decided I shouldn't be hypocritical and I should be me, which actually makes sense at this point in my life. And
Justin, are you there? Could you pitch in, and we'll hope Louise comes back?
Yeah, let's see. See if it's coming back or not.
We can circle back to her as
yeah, sure. So it's as Dr. Aronson said, a huge question, and I think that certainly a big part of it is practicing the alternative, and that means bringing all of us together in the health professions to really build systems that provide that person-centered care, that not only are focused on bringing great quality care to individuals, but also taking care of caregivers, and attending to the political economy of caregiving, because that is an absolutely critical aspect of a thriving elderhood community. So there's so many different ways in which we need to tackle that problem, but practicing an alternative is critical.
Mm-hmm. We seem to have lost Louise Aronson. I think our technician is trying to reestablish contact, but in case that can't happen, I think Justin and I will continue this conversation and hope that Louise can rejoin us. One of the things I was thinking about, and Justin, I'd be interested in your thoughts, one of the challenges of medicine and actually society seems to be that medicine really likes to be able to fix things, to cure things. And in some ways, aging is something we go with, we don't necessarily fix. We can improve some of the conditions around it. but it also makes me think of 19th century institutions where the quote unquote incurable were often put in different kinds of institutions that medicine wasn't quite so concerned about.
Yeah, absolutely. I think, and I'll to that end, since we're minus Dr. Aronson's voice, I will quote her and the end of her book on that issue. I mean, she has this really wonderful line toward the end of her book that I sort of starred, and she says, "Care is never futile, though treatment can be."
Yeah.
And I think that conceptualization, she also talks about working with a medical student at one point and going to a brand new wonderful program for all-inclusive care of the elderly. And the medical student sort of paused and said, "This isn't medicine, this is taking good care of people." And, I think that mentality of thinking about the whole person, not just in terms of medicine, but in terms of their stories. And that's something that certainly from Dr. Aronson's work, we get a lot of important stories, and attending to someone's story, even as we attend to medical or health concerns that someone may have.
Mhm. So word is that Louise Aronson may totally have lost her internet connection capabilities. So we will continue with this conversation, and I'm happy that Justin's been able to quote Louise and keep her in the conversation. We have one other thing that she mentioned that I thought made good sense was that this idea of really designing for attractive ways of accommodating aging, whether it's in products or the places that we live, the kinds of comprehensive care that we are providing, that it looks and feels good, and that it helps people look and feel good. And Justin, you might want to say a little something about the innovative care program that you are leading now that works with people in their homes and integrates a number of different things into the good care for aging persons.
Yeah, and I think to do my best to channel what Dr. Aronson would say, and as those of you who've read her book know that she's done quite a bit of house call medicine through the UCSF program for many, many years, and so she certainly brings that perspective as well. I think, um, uh, and to the point of at the end of her wonderful talk about these new systems that are very much a part of the fabric of healthcare now in the United States. Oh, she's back. Good.
But she didn't hear my question, so.
Yeah. I think that making these systems not just innovations, but reality, whether it's home care medicine or any other new person-centered models that are bringing the best of modern medicine and social care to people where they need it. So I'll pause there.
Welcome back, Louise.
Our entire system went down. I am so sorry.
We're happy to see you again. We have just a couple more minutes, but Justin was just talking about, and he was actually able to, while you were gone, quote from your book as well. So you stayed a part
Thank you, Justin.
part of our conversation. But he was also just saying that you had extensive experience with house calls. Mm-hmm. And it strikes me that there are ways that in what we see and encounter in a house call can help to inform us about perhaps how best care should change, and medicine and structural care should change to better serve the older people among us.
Well, it's actually turning out to better serve almost everybody. So most of the startups end up coming to you, so this is for people of all ages, people with kids at home, people who are at their work and don't want to leave. So a lot of the innovations have to do with doing things that we already know work particularly well for older adults. The benefits are different at different age groups. And that's one of these things where you don't need so much equality as equity, the difference being everybody gets the same thing versus everybody gets what they need. But sometimes the same vehicle can give people what they need. I also think one of the reasons I became a geriatrician was that, all the biology and all the medical stuff is fantastic, but it was so clear to me that how that works or doesn't work depends on the individual, their social and physical and cultural context. And for geriatrics, we have to know who you are and who's around you, and what do you value to make the right decisions. But as with so many things in healthcare, if you can create a system that works for the people who are most complex or have the most challenges in their lives, then you have a system that works for everyone. But if you do the opposite, if you make a system that works for the most advantaged, you leave everybody else out. So part of what really sort of blew open the book for me and its format was that I had been trying to write this aging book, and I had written a fairly traditional book. I'd actually analyzed all the doctor books that had, that I thought were good and had done well, and a bunch of others. And they tended to have, 9 to 13 chapters, each of which was 25 to 35 pages. So I was written that. I was kind of bored. So I was writing these essays about medicine. And it suddenly occurred to me that they were all part and parcel of the same thing, that medicine does to a variety of populations. And, for instance, there's actually financial incentives for people to be critically ill. So critical care doctors get more than hospital doctors, get more than outpatient doctors, which, if you think about it, is the exact opposite hierarchy for what we want as human beings. We want to require outpatient care. Okay, if we absolutely need it, we'll go to the hospital, and we really hope we will never need tertiary care. And then all the health systems that do better than ours are the ones that value primary care. And I think if we valued primary care, we would do more home care for people of all different ages. And maybe telehealth and COVID will help us get there. I mean, it's kind of interesting.
Thank you. I'm afraid we're at the close of our hour. We have so valued having Louise Aronson with us, and having you back with us has been very important in these closing minutes. Thank you to you and to Justin Mutter for some wonderful insights into how aging is indeed a synonym for living. And so we all need to be doing this. Please join us next week. We have Rebecca Reimel with us. She's the former president and CEO of the Pew Charitable Trusts. She's going to be talking about Anchored in Nursing, a Life in Leadership. Join us then. Thank you again, Justin Mutter. Thank you, Louise Aronson.